Hello, I am Joe Wathen, a pediatric emergency physician and associate professor of pediatrics at the University of Colorado School of Medicine, and this just-in-time training series topic is the management of the pediatric patient with a respiratory viral illness. These are the disclosures. I have no relevant financial interest or relationships to disclose. The agenda of this talk includes the awareness of the impact of annual surges of respiratory infections in children, recognizing early and late signs of pediatric respiratory distress, considering which children are at increased risk of more severe manifestations of viral illnesses, and understanding the management options and approach in caring for pediatric patients with a viral respiratory illness. Having epidemiologic tools allow for real-time tracking of these respiratory pathogens. One such tracking tool is seen in this figure called BugWatch, which is produced at the Children's Hospital of Colorado and reports out positive pathogen counts on a weekly basis. The top 9 listed pathogens represent the most common sources of respiratory illnesses in children. These pathogens surge and recede in waves throughout the year. This data is felt to be indicative of not just Colorado, but of the larger region and national trends. This is an open access data source and will be listed in the resources slide at the end. The real result of these viral outbreaks is how they affect healthcare systems and hospital admission rates. Health departments accumulate data on the impact to hospital pediatric admissions as seen in this figure. The latest impact shown, the winter of 2025, illustrates how RSV and influenza account for the spike in hospital admission rates. Many seasons, this leaves pediatric hospitals at full to overflow capacity. Each year, there is a capacity stress to hospitals during these surges. When we look at the 22-23 season, we saw an unprecedented bed expansion at pediatric hospitals as a result of the triple-demic of RSV, influenza, and COVID. Hospitals established new units and beds in places not used previously, formed alternative care areas. There was significant emergency department boarding of patients, and even the use of outside tents for triage and medical care. Hundreds of surgical procedures and scheduled admissions were canceled, and a deferral process for accepting patients was initiated, limiting or delaying the ability for outside hospitals to transfer their patients. The end result is that many non-pediatric facilities needed to manage or hold on to for longer time periods pediatric patients with respiratory illness. The first step in managing a surge of pediatric patients with a respiratory illness starts at the front door or triage area. Children have some unique anatomic and physiologic qualities. The pediatric assessment triangle is often used as a consistent, reproducible tool that can be done quickly from the front door. It starts with general appearance. How is the tone? How interactive is the child? And the verbal response. Then a quick look at breathing. Are there retractions, abnormal breath sounds, signs of distress, or apnea? And then what is the circulation to the skin? Is there pallor, mottling, or cyanosis present? A more detailed assessment of respiratory distress includes evaluating for both early and late signs. The most common sign of respiratory distress in children is tachypnea, especially in infants. It is more efficient to increase the respiratory rate instead of the tidal volume for increased minute ventilation. One can see infants breathe 70, 80, or even 100 times per minute. Additional signs include nasal flaring, which increases the size of the upper airway and airflow, retractions that occur when increased muscular activity causes a collapse of the cartilage and soft tissues. This can be seen in a number of places with a compliant chest wall, such as suprasternally, intercostally, and subcostal. One should listen for abnormal audible sounds such as stridor or wheezing. Seesaw or belly breathing can also be present. It's most important to recognize late signs of respiratory distress in children and quickly remedy these. Late signs include extreme tachypnea or fatigue with slowing respiratory rate or apnea. Additional signs include cyanosis, deep and severe retractions, poor perfusion, altered mental status, and grunting, which is an expiratory noise heard in infants and young children with closing of the glottis in an attempt to increase end expiratory pressure. Finally, one should be vigilant in infants for the presence of head bobbing. This occurs in infants with accessory muscle use in combination with decreased tone and lethargy, causing the head to bob, and can be a signal for impending respiratory failure. When evaluating children with respiratory distress, age impacts anatomy and physiology. Infants less than 6 months are obligate nose breathers, and viral infections can lead to obstructed nasal passages. Nasal suctioning alone in these affected infants can bring a high respiratory rate down to nearly normal. This is not the same for older children. Young children also are diaphragmatic breathers with flexible cartilaginous rib cages. Therefore, they show more physical signs of respiratory distress, such as retractions and belly breathing, emphasizing the importance of exposing the chest to visualize. Finally, there's a growing number of young children with chronic medical conditions and congenital anomalies who may arrive with home ventilator devices. It's important to differentiate the difference between respiratory distress and respiratory failure. Respiratory distress can be improved with compensatory methods or treatments, while respiratory failure cannot. These patients will have hypoxia despite oxygen administration, signs of inadequate ventilation such as air hunger, distress, tachycardia, diaphoresis. Lethargy from CO2 narcosis is a late sign, however. Assisted ventilation is needed for any of these signs when they present and suggest respiratory failure. When managing children with respiratory infections, it is important to be aware of those that fall into high-risk categories. Those that are less than 2 years of age have chronic medical conditions such as asthma, chronic lung disease, or have underlying cardiac conditions, immune suppression, or morbid obesity are all considered high risk. This listing also indicates those who should be treated with antiviral medications such as Tamiflu if they test positive for influenza. Respiratory viral infections can localize to the upper airways, the lower airways, or to the lung tissue parenchyma. Upper airway illness can be a simple upper respiratory infection such as a cold, or can affect the larynx and trachea and present as a croup-like illness. Croup can be a very scary presentation for both the parents and healthcare workers as it presents with upper airway narrowing and obstruction. Major signs include barky cough, hoarse voice, stridor, inspiratory upper airway retractions, drooling, and poor air entry. Common viruses that cause a croup-like illness include parainfluenza, influenza, and COVID. Treatments include utilizing a calm approach, such as keeping the child in the mother's lap, oxygen, and racemic epinephrine for stridor at rest, which can be repeated as needed. The use of steroids, such as dexamethasone, and at last resort, the use of Heliox. Respiratory infections that affect the lower airways represent the bulk of respiratory illnesses in children. They can cause obstruction of the lower airways, such as trachea, bronchi, or bronchioles. RSV is the most common virus leading to bronchiolitis, and it often occurs in large seasonal outbreaks, affecting primarily children less than 2 years of age. Other viruses can cause bronchiolitis, such as COVID and influenza. Signs of these infections stem from mucus plugging of the nose and smaller airways. The lower airway effects not only are heard as diffuse rhonchi, but also as expiratory wheezing. Commonly, additional respiratory distress findings include retractions, tachypnea, and grunting. Some young infants can present with apnea prior to showing lower airway symptoms. What are some of the management recommendations for bronchiolitis? The motto we use is rest is best. This means that in general, supportive care and time usually is the best approach. The most important part of supportive care is suctioning after saline administration to the nose. Hospitals can teach this skill and provide suctioning devices to parents. Supplemental oxygen is often needed, and in some location, if it's a half liter or less, these patients, after an observation time, can be candidates for discharge from the emergency department with home oxygen. Many children with bronchiolitis have a drop off on their feeding and then present as dehydrated infants and children. Rehydration is important and can be accomplished either orally or with IV fluids. If your patient's febrile, treating this will help take away the tachypnea that is often associated with fever. Assisted ventilation will need to occur for those with continued signs of respiratory distress not relieved with these initial measures. Things that have not been shown to provide any benefit include routine administration of steroids, hypertonic saline for secretion removal, and routine albuterol. Although those with known reactivity, chronic lung disease, or atopic conditions may benefit from albuterol. Finally, the routine use of antibiotics, viral testing, and obtaining chest radiographs are not helpful tasks. Lung tissue disease processes, such as pneumonia or pneumonitis, may also occur with viral infections or as a bacterial complication. Lungs become stiff with fluid accumulation in the alveoli, air sacs, or interstitium, or both. Distress is seen during both inspiration and expiration. Hypoxia and increased work of breathing have a stronger likelihood ratio of indicating a pneumonia than tachypnea or auscultative findings. Concerns for bacterial pneumonia increase in those greater than 5 years of age, those with moderate to severe respiratory distress, prolonged fever, and inadequate pneumococcal vaccination. Treatment for uncomplicated pneumonia, thought to be bacterial, can be provided orally with amoxicillin or IV with ampicillin. In a patient presenting with respiratory distress, what are the first steps to consider? First, remove clothing so you can visualize the chest and abdomen and evaluate the ventilatory status. Next, optimize the airway positioning. This may require a towel roll, as seen in this image of an infant whose large occiput flexes the airway. Ideal airway positioning occurs when there is a horizontal plane from the bridge of the nose to the chin and from the ear to the suprasternal notch. The next step is to relieve any obstructions with suctioning, jaw thrust or chin lift, and the potential use of a nasal or oral pharyngeal airway. Finally, place appropriate oxygen, monitors, and treat any fevers. There are many ways to provide oxygen and assist with ventilation. This will require appropriately sized pediatric equipment and should proceed in the order listed here. When choosing how you're going to manage respiratory distress, it is important to be goal-oriented and not procedure-oriented. Your goals should be to provide adequate oxygenation and ventilation and to do no harm. So start with the least invasive options and advance as needed. If low-flow oxygen is not adequate, the next step is heated high-flow oxygen through a nasal cannula. The airflow should be both heated and humidified at rates of 1 to 2 liters per kilogram per minute. It is important to suction the nose prior to administration and intermittently after for the best chance of efficacy. Pick nasal prongs that fill approximately 80% of the nair diameter. Increase the flow rate with the goal of capturing a more normal ventilatory effort. The reasons to escalate to non-invasive ventilation include continued distress at max rates, recurrent apnea, an FiO2 of greater than 70% at maximal flow for 2 hours or longer. One transport pearl is that many hospital transport systems, although able to transport with heated high flow, they are unable to hook up humidification. If this is the case, one can administer a saline nebulization during the transport to avoid having the secretions turn into concrete and lead to obstruction. Non-invasive ventilation can be provided by either BiPAP, bilevel positive airway pressure, or AVAPS, average volume assured pressure support. BiPAP provides a change in airflow instead of a continuous flow and assists in CO2 clearance. Usual IPAP and EPAP settings are 12/6 and can be increased from there with a goal of seeing chest rise and approximately 10 cc's per kilogram of exhaled volume. AVAPS is the preferred non-invasive method in many hospitals. It allows for natural variability with an averaged tidal volume calculation and is felt to be more comfortable. In children less than 2 years, the use of a scuba mask, as seen in this lower picture, is common. One transport pearl with non-invasive ventilation is to know that the usual venting face mask must be switched to a non-venting face mask so that oxygen is not depleted during transport. This switch may require tidal volume settings to be decreased with the air leak removed. At the end of our management escalation process is the act of endotracheal intubation. Patients to consider this in include those with respiratory failure despite non-invasive measures, those with apnea, those on maximal BiPAP settings that are starting to fatigue, those with a reduced level of consciousness, high risk of aspiration, or there's a prolonged transport time with an at-risk airway. LMAs can serve as a backup plan for those that are difficult to intubate. And when transporting, remember to secure all devices, sedate your patient, and to perform suctioning prior to leaving. In summary, respiratory viruses have yearly surges that result in many non-pediatric centers having to take care of children with respiratory distress. This requires proper training and equipment. Management of respiratory infection should center on respiratory assessment optimization and attention for signs of respiratory failure. The spectrum of care should start with the least invasive procedure and advance in a goal-oriented approach to ensure optimal oxygenation and ventilation. I want to thank you for listening to this training and provide you with some resources for your consideration.